Hi, and welcome to the Introduction to Quality Improvement. This video clip is brought to you by the Northern Health Physician Quality Improvement Program, which is funded by the Specialist Services Committee under the Doctors of BC. The Physician Quality Improvement Program strives to provide physicians with quality improvement education and support to incorporate QI methodology into their daily practice. My name is Shelley Movold, and I work with Physician Quality Improvement as a coach at UHMBC in Prince George.
My name is Laura Bruff, and I work alongside Shelley as a physician mentor for PQI at UHMBC.
So we're going to get started into our program. We'd like to acknowledge the traditional territory that we're joining you from today. We're joining you from the traditional territory of the Lheidli T'enneh people in Prince George. We'd like you to take a moment to consider what territory you're joining us from. We'd also like to let you know that we don't have anything to disclose. And now we'll get started with the agenda. So today we're going to be talking about the triple and quadruple aim in healthcare and how that affects quality improvement. We're going to be talking about dimensions of quality, talking about the differences between research, quality assurance, and quality improvement, the foundations of quality improvement, and then one of the methodologies that's used to do quality improvement called the model for improvement. We'll also summarize the day by talking about steps in doing QI projects. So to start with, let's start with the triple and quadruple aim in healthcare. So basically, the triple aim talks about better outcomes. So looking at population health and keeping people as healthy as possible in community, lowering costs, making sure that we're financially responsible with the costs that we're using in healthcare, and keeping costs down so that we can sustain the healthcare system well into the future. And finally, experiences of care. So looking at the acute care experience for patients and making sure that that experience is as good as possible. So that's the triple aim. When we move to the quadruple aim, we basically keep what's part of the triple aim, the better outcomes, population health, lower costs, keeping a sustainable healthcare system, but we split the experiences of care into two. So it's still the patient experience, but it's also the clinician experience. And in today's day and age with healthcare workers at their breaking points, it's really important that we consider their experience as well. We need to keep our clinicians, our physicians, and our staff as healthy as possible, because without them, we don't have a healthcare system. So when doing quality improvement work, oftentimes your projects that you're working on they fit somewhere within the quadruple aim. And it's a good idea to kind of think about how your quality improvement project works within that quadruple aim and what it's supporting in terms of improving the system. So next up is the quality matrix. And this quality matrix that you're seeing here is brought to you by the BC Patient Safety and Quality Council. Basically, a quality matrix helps you to sort of illuminate where on the spectrum of quality or dimensions of quality your project is sitting. So there are different quality dimensions. There's those from the individual perspective and those from the system perspective. With respect to the individual perspective, we look at respect, making sure that we're honoring patients' wishes and choices and values, that we're being safe and that they're not experiencing harm and they're secure, that the system that we have is accessible to all people, it's appropriate for their needs or the community context, that things are effective, that the outcomes that we're intending are what actually happen. And finally, the systems perspective, that things are equitable and that we have a fair distribution of services for all those that need them, and things are efficient. So making sure that the system that we're working in is producing the most that it can for the resources that we have. And then along the side here, we have the areas of care. And this is kind of the lifetime continuum. So you start with the early years in childhood, then you go into the strengthening health and wellness. So looking at adults and keeping them healthy in the community. Then you go to the acute care when someone had an acute event and we're going to try to return them to normal wellness. Or sometimes people have have disabilities or chronic conditions that makes them change the way they live, but they can manage them in the community. And finally, coping with transitions of life. So if someone is palliative, helping them cope with that transition. So when you're doing quality improvement work, oftentimes you'll be doing it in one or two of these boxes on this matrix. You'll be working with a certain age population, and you'll be working in one or maybe two of the different dimensions of quality. So it's a good exercise to sort of think to yourself where the quality improvement work that you're working on fits in this matrix.
So what is quality improvement and how does it compare with the other dimensions you might be familiar with? Well, we know about research. It's all about discovering something new. The COVID vaccines would be a really great example of that. Quality assurance is about meeting a standard. Think driver's license or medical school exams. And quality improvement is about taking something already in existence and making it better, like improving access to medical imaging. Research requires a lot of data and a really big sample, just in case someone challenges your findings. Quality assurance is a pass-fail situation where every piece of data or answer is important. Quality improvement requires just enough data to show that things are getting better. So what is continuous quality improvement? Well, we know it's patient and family centered. It encourages thinking about the entire system. By that we mean, view the system from all the different perspectives, include all the people that affect the process or touch the patient. These are called your stakeholders. Maybe even consider including the patient in your project. Imagine if you initiate a project that has nurses at the triage desk ordering x-rays upon a patient's arrival. You need to check to make sure not only do you have the medical imaging staff available, but you have porters to bring those patients back and forth. Otherwise, you haven't had any impact on improving the flow in emergency. Continuous quality improvement is regarded as a team sport. It's rarely successful when done in isolation. So build your team and pay attention to how they are involved in your project. It requires measurement. Collect your data, analyze and review it as you go along to understand if the changes that you're making lead to an improvement. And finally, recognize and share what you've learned, be it a success or a failure, so that others don't have to recreate the wheel.
So with quality improvement, there are different methodologies that you can use and different frameworks. There's Lean, there's Six Sigma, and then there's the model for improvement, which we're going to talk about today. But no matter what methodology you choose, they all have similar consistencies or frameworks. They all have a clear purpose of change. So you're looking at changing the system you're working in and trying to have a purpose around that change. You're looking at testing things out and trialing things until you find something that works well in that system. You need data. So you need to be able to measure your system to start. What's the current state? How is it functioning to start? And then as you're starting to make these changes, how does it change? How does the data shift and hopefully prove that the change you've made is effective and is working better? And finally, teamwork. All quality improvement requires a team approach. As Laura mentioned, quality improvement is a team sport, and we really need to have different perspectives of what the system is doing. It can't just be one perspective or one viewpoint of how things are functioning. We'll get a better sense of the actual problem if we bring others into the mix. So let's talk a little bit about the overall goals of the different methodologies. With Six Sigma, it's about reducing mistakes. So you're kind of looking for things that aren't working or are mistakes in the system, and you're finding ways to reduce them. With Lean methodology, you're looking to eliminate waste and increase efficiency. So normally with lean methodology, waste centers around the patient. And anytime a patient is waiting or not getting a service, that would be considered waste. So if a patient comes into the emergency department and is waiting to see a physician, the time that they wait would be considered waste time. And we want to reduce that as much as we possibly can. And that will make the system more efficient. Now, the third methodology, and the one that we'll spend the most time on today, is called the model for improvement. And the model for improvement works really well in healthcare. And basically, it's just applying 3 questions and then doing a number of PDSA cycles or cycles to test out the change ideas that you have. So let's dive into the model for improvement. First off, the 3 questions. So the 3 questions that you're going to ask yourself with the model for improvement is, what are we trying to accomplish? That's our problem and our aim statements. How will we know the change is an improvement? That's our data piece. We need to measure the system. We need to know what it's doing at baseline or at current state. And then we need to know what it's doing throughout the project. And then hopefully after the project, we're able to sustain those gains. And the third question is, what changes can you make that will result in an improvement? So those are your change ideas. And those are the things that you're going to test out to see whether or not they're going to work in the system. So those being our 3 questions, we also have PDSA cycles. So building from your change ideas, you plan what your test of change is going to be, then you do it, then you study how it went with the data that you've collected, and then you act. So what that typically means is based on what you've done with that first test, you can build your next test and your next test. And oftentimes these PDSA cycles are small to start, and they build and grow as you're learning more information and knowing what's working and what's not working in the system.
So, first question, what are we trying to accomplish? The problem statement is the story about the problem, what is wrong and what we are trying to accomplish or change. It describes the impact on patients, providers, the system. It uses facts or perhaps an example of a patient journey to illustrate the extent of the problem. It describes why it is important. Is it to improve safety, decrease costs, or increase satisfaction? And it identifies what dimension of the quality matrix this particular problem addresses. In your problem statement, avoid jumping to conclusions about the solution. Going through the whole process allows you to contemplate innovative ideas that are more likely to be effective. So let's practice. Remember, the key elements we're looking for in your problem statement are the impact, the facts, the why, and the quality it addresses. So, Mountain View Care Center is a long-term care home with 100 residents. In the last 6 months, the number of falls in the North Wing has increased by 30%. Now, looking at our quality matrix, what part of the dimensions of quality does this address? Well, safety. And what population are we talking about? Those living with disability or illness, the elderly. So, what would be the impact? Well, we know falls decrease quality of life. They increase hospital visits. They require more surgeries. They're an increased cost to the system. The patient, the family, and the caregiver all have decreased satisfaction. The facts? Well, we know in the last 6 months, there's been some reason that caused increased falls in this care center, but we don't know why, and we need to dig deeper to sort that out. Have they changed the flooring? Have they dimmed the lights? Are they mobilizing the residents more often and having increased falls as a result? Why is it important? Because falls contribute to increased morbidity and mortality in the elderly. And what quality issue? Well, we've already put it on the matrix. Next, what are we trying to accomplish in the aim statement? Now we've told the story on the why, we will create the aim statement, which is a descriptive statement that addresses the who, the population we're talking about, the what we will improve, the where, either the department or the geographic location, the how much, is it going up, is it going down, is it a percentage, is it a number, and by when, a date or a time. You should consider using SMART goals when creating your aim statement. Be specific, be able to measure and collect your data, be reasonable. Choose something that's important to your team, your patient, and you, and be very specific about the time. Usually your project should be about 3 to 6 months in duration. So let's practice the aim statement. What do we want to accomplish? We want to decrease falls in residents. Where? In the north wing specifically of the Mountain View Care Center. By how much? Well, we'd like to go from 10 down to 2 per month. That would seem reasonable. By when? 3 months from today. Our aim statement then is to decrease the number of falls in the north wing of Mountain View Care Center from 10 to 2 by 3 months from today. Scope is probably one of the most challenging aspects of doing a quality improvement project. It defines the edges of your project and allows to keep your team focused on what is inside your project and what is outside your project. One of the things you need to do is determine what are outside your sphere of influence. Are there policies? Are there procedures? Are there union positions or job descriptions that actually you don't have any effect on? Think about investments of time, resources, and costs to doing this project. And be creative around resources you might be able to use with regards to student projects and internships. If you have a large project, consider breaking it down into smaller pieces to start. Remember, if a project seems too easy and small, it's probably been scoped appropriately.
So the second question in the model for improvement is, how will we know that the change is an improvement? And that speaks to our data piece. So with our data piece, we're looking to assess the baseline, measure and find out how the system is working at current state. And then as we go through the project, we're looking to continue to collect data and analyze it regularly to make sure that what we're doing, the changes that we're making, are actually causing the effect that we want. So it's also important with quality improvement to make sure that we're collecting continuous data. And there is sometimes an urge to do pre and post type data, but it can be a bit misleading. So if you look at the graph that's on your screen right now, we've got a before and an after, so a pre and a post. And this was wait times for a primary care facility or primary care clinic, wait times to see the physician. So to start with, it was 8 days. And then after the project, it was 3 days. So that's actually showing quite a great improvement. And by looking just at this data, you would think that they did a great job and lots has changed. However, if you look at it in continuous data, you'll actually be able to see that the data didn't really shift at all. The 8 weeks was the top, sort of the top of the continuum, and then 3 was at the bottom. And the data actually every week seems to go up and down within that sort of grid, right, between 8 and 3 days. So it's much more important to sort of look at data in terms of continuous data, because often things are not going to be exactly stable. They're going to have some flux in the system. And so you can measure that flux and be able to see whether or not the changes that you're making are actually changing the system more than outside of that 8 to 3 range. So continuous data, if at all possible in your quality improvement project, is the best way to go. When you're thinking about what you're going to measure in your system, it's important to try to aim for collecting at least 3 measures and no more than 8. You don't want more than 8 measures, or it becomes very convoluted and lots of collecting and can be time consuming. So when we're talking about measures, we talk about 3 types of measures. We talk about outcome measures, process measures, and balancing measures. And so an outcome measure, it's related back to your aim statement. So if you think about your aim statement, what is your goal for the project? What are you trying to accomplish at the end of the day? So where are you going essentially with your project? And if we use an example from the OR of surgical site infections, if our overall outcome is to try to reduce the number of surgical site infections, then measuring the percent of people that get surgical site infections would be an outcome measure. That's sort of where we're going with our project. A process measure is measuring something that's happening along the way. So it relates to the improvement idea. So what are you doing to get to your end goal, essentially, is what a process measure is. So again, back to our example, if we're thinking about trying to reduce surgical site infections, then maybe using a different hair removal process that's considered best practice might be a good way to address reducing surgical site infections. So if we measure the number of people that get this new hair removal process, then that's a process measure. That's something we're doing along the way to get to our overall outcome. And finally, there's balancing measures. So balancing measures are kind of like ripple effects. You're making changes in the system, and what's the impact that has on the system? So what else is happening in the system as a result of the changes that you're making? Now back to our example again, if we're using this new best practice hair removal process, but maybe it's a little bit more time consuming than the original process that we used, and maybe staff aren't very happy about that, then we might want to do a patient or a staff satisfaction survey to check what their thoughts are on this new hair removal process. Because at the end of the day, if the staff aren't happy, this probably is going to be a very hard project to sustain. So what you're going to want to do is have those balancing measures in there just to make sure that you're not getting sort of a side effect of the changes that you're making, because that can affect sustainability of things. So it's important to try to have at least one outcome, one process, and one balancing measure, and possibly more, depending on your project and what you're trying to accomplish.
So let's practice. If your quality improvement project is about having all the information on the chart before the physician actually sees the patient, then recording or measuring the number of visual acuity checks done on patients with eye complaints prior to the physician assessment would be an outcome measure, because it speaks to your overall goal of having the information on the chart beforehand. How about if your project is about decreasing the number of falls in patients post-surgery? Then the number of patients receiving crutch instructions prior to discharge might be a process measure, because having crutch instructions is one way of reducing falls before sending patients home. If your project is about improving flow and capacity through a critical care unit, and one of the change ideas is to reduce the time on a ventilator, then checking re-intubation rates when working to reduce patients' time on a ventilator would be a balancing measure, because if re-intubations increase, then it means that the change idea actually isn't working very well. So the third question, what change can we make that will result in an improvement? Where would you come up with change ideas? Well, during quality improvement training, you will learn about tools to generate change ideas. You'll learn about driver diagrams, fishbone diagrams, root cause analysis, but you can also look to best practices and standards. You can review safety events on your patient safety learning system, or review patient complaints in a certain area of the hospital. You can build on other projects that have been done in your department, in your hospital, or review projects that have been done at different conferences. You can look at the current system by doing patient journey maps or process maps. You can look for waste in the system, whether that's time, materials, or talent on your team. Or you can look at embracing the creativity of your team. Often we need to try different ideas to actually achieve our aim. Your PQI team will assist you with generating these ideas. So finally, those PDSA cycles. Plan, think about what you will try, do it, and on a small scale, maybe one patient, maybe one shift, study it, collect the data, and then act, review the data, tweak the idea, and try it again. Why do we have to do it multiple times? Because we don't know if it will work, how it will work, when it won't work, how it will affect other parts of the system. So putting it all together, the model for improvement, 3 questions. What are we trying to accomplish? How will we know a change is an improvement? What changes can we make to result in an improvement? And those PDSA cycles.
So now we're going to talk about a charter. And a PQI charter is something that we use to sort of keep track of the project throughout the length of the project. It's something that you continue to build on and continue to wordsmith as you go through a project. Basically, it discusses your clarifying purpose. It keeps you on track, makes sure that you know who your team members are, what their roles are, where the project is starting, and when the project will end. So the next slide here helps us to look at one example of a charter. This is our PQI charter that we use. And the first sort of top box there, just the title of your project, who your sponsor is. One thing to note with doing quality improvement is you always need a sponsor. A sponsor is someone from administration or the health authority that can help you, first of all, to support you to do this project, but also to help you to navigate if you do run into any roadblocks or things that you need to sort of get some help and support from the health authority on. It's good to have that person sort of in the know from the very beginning and get a sense of what your project is and what you're trying to accomplish. So identify that sponsor early. And you have your start date and your end date for your project, where the project's happening, who's on your team. And a RECCE score, what an RECCE is it's basically the quality improvement version of research ethics. So with research ethics, it's quite a long and involved process. And in quality improvement, it's quite a bit shorter. Basically, it's a survey, yes or no type questions that you fill out to sort of make sure that you're on track with your project. And maybe there's a few areas that you want to tweak in terms of the ethics of the project. But it's quite a quick process in comparison to research. And finally, you want to consider whether you want a patient partner on your group or not. Potentially, you could include a patient partner as part of the project and get their input on the system and how it's functioning. So next, you go through your project proposal. And this is your problem statement and your aim statement, which we've talked about today. And your business case has to do with your triple aim and your quadruple aim. So remembering back to what we talked about at the very beginning, and how does your project fit into that quadruple aim, whether you're keeping people healthy in the communities, whether you're looking at cost savings, whether you're looking at physician and staff wellness, or whether you're looking at the acute care experience for patients. So talking about your project in terms of that can help to sell it. Oftentimes when you're making a business case, so to speak, you're trying to sell your project and get people involved and get people excited about your project. Those are the kind of things that you want to plug or promote. The next page goes through scope and talks about sort of where your project will begin and end and things that you need to kind of keep in containment with the project, remembering that it's only 3 to 6 months. So if you have a very large project, you probably want to break off just a piece of it that you can accomplish in that time frame and think about doing that piece first. Your risks and mitigations are often a good idea to get your team together early on and think about, what are the potential risks with doing this project? And what are the things that we can put in place to hopefully circumnavigate those risks? And remembering your sponsor is a good person to have on board to be able to help you mitigate some of those risks. And then we go through our measurement plan. So remembering back to the outcomes, process, and balancing measures, and that we're trying to come up with 3 to 8 at most measures that we're wanting to track throughout the project. And then finally, the last page, double-sided page of your improvement charter allows you to identify your team roles. So who's on your team and what are they going to do for you on that in terms of that project? And communication. Communication is a big part of doing quality improvement, and you're going to want to communicate often when you're doing a project. So you want to communicate before you even start the project that this is what's going to happen. So get ready for some quality improvement work. Then you're going to want to talk to people about your project while it's happening and let people know how things are going and keep on top of the progress that you're making. And finally, at the end of the project, you're going to want to communicate out how it went and let people know, all your stakeholders know what you've learned and what things you were able to change. So this part of the document helps you to sort of keep track of all that communication that you're doing. What's your key message? Who's your audience? Who's going to do the communication? It helps you to keep on top and organized of that communication that's happening. And finally, on the back page, what are your change ideas? So again, with your team, you're coming up with things that you'll want to trial. And then your PDSAs and initial activities, you're going to want to keep track of that and how things are going with the PDSAs that you're trying. So again, a charter is not something that you're going to do all in one day. You're going to do it throughout the whole course of the project, and it just kind of keeps you on top of how the project is going. Sometimes you'll need to tweak things as you go through, and things might change or alter a little bit, but this document allows you to keep on top of things, keep organized, and keep a direction and focus for the work that you're doing. So last but not least, we wanted to talk a little bit about the steps to doing a quality improvement project. The first thing, of course, that you want to do is to decide what needs to be improved and what the project is going to be all about. And then, as we've mentioned, it's important to find a sponsor. So somebody within the health administration that can help you to navigate your project, to support you in the project. Oftentimes you'll need team members, so it's a good idea to have that administrative sponsor because they can help you to identify who the team members should be. Maybe you need a nurse, maybe you need a unit clerk. They can help you to free up some time so those people can help you with the project, all of those kinds of things. So once you have your sponsor, you build your team, and then you dig down, and as a team, you really try to understand that system. You do what we call is a root cause analysis. And so you're looking from the system at different perspectives, right? You're looking at and trying to dig down and figure out what is actually causing the problem that you're seeing, and doing an analysis from all different vantage points, getting some data, really understanding what that system is, so you can do a really good problem statement that's nice and thorough. Once you really understand that problem, you can come up with some change ideas and you can test them out and see how they go. Some things will work and some things won't. And you need to learn that through small tests of change, the PDSA cycles. Once you've found what works, then you're going to want to implement that and sustain those changes that you've made. A big piece of quality improvement is trying to sustain those gains that you've made. So once you've been able to do all that, the last but probably most important thing is to share your learnings. Oftentimes, you want to let people know, even if it wasn't successful, you want to let them know what you did and what you learned from it, because that way they won't recreate the wheel. It's really important to share what you've learned so that people can build on what you've accomplished, and also to learn from what's happened and be able to use that in their own practice, and continue to do quality improvement and build the culture. So in terms of physician quality improvement, we do have coaches like myself and mentors like Laura. And we support physicians to learn more about quality improvement, as well as to do projects, to ask questions to support you with those projects. We have evaluation analysts and data analysts that can help you get the data that you need, or to evaluate your project once it's complete. So we have lots of resources that you can access within the program. And we do have a website. So this is our website, and we'd love you to check out the website. It'll tell you about some of our offerings and let you know what's happening in physician quality improvement. And we'd really like to recommend our virtual action learning series, which we call VALS. And it's basically a 6-month program, and you meet 8 times in those 6 months to go over some quality improvement information and education. And then you do a project alongside that education to really cement what you're learning in terms of quality improvement and work on those skills and tools that you're learning. So that's our email information there as well. We encourage you to check out our website or to email us with more questions. We'd really love for you to come out to VALS and join us for a session for the cohort. And we'll also have other educational opportunities as well that you'll be able to check out on the website. So please don't forget to check out that website, and if you're interested, give us an email. And finally, at the bottom of this video link, there should be an evaluation that you can click on. We'd love to hear from you and let us know what you thought of this video, and then we can improve it and continue to do some quality improvement for our own program. So thank you so much for joining us today, and welcome to the quality improvement world.